Hello, this is Dr. Anthony Jan. This is the second part to our three-part series on chronic pelvic pain. Today's series is going to be a discussion about chronic interstitial cystitis, now commonly called painful bladder syndrome. In this series, we'll talk about the diagnosis of chronic interstitial cystitis, current treatment modalities, and long-term consequences, and how it affects women. Chronic interstitial cystitis or painful bladder syndrome affects both males and females. However, the incidence in females is about 3 times in males. We'll spend the next couple of minutes talking about this chronic pain condition. Going by its current name, painful bladder syndrome, it's to indicate that women have pain coming from the bladder. However, there are other symptoms associated, which include urgency and frequency. The patients seem to go to the bathroom quite often. They urinate small amounts of urine, and they also have urgency, which means that when they have to go to the bathroom, they typically have to run to the bathroom. In terms of incidence, it has a wide age variance from younger women as young as 16-year-old to elderly women in the late 70s to 80s. However, the peak incidence occurs with women within the 30s to 40s. By way of the disease condition, it is thought that the bladder has a lining called a glucosaminoglycan layer, which is a protective layer in the bladder. However, in patients with interstitial cystitis or painful bladder syndrome, the bladder lining is leaky, and therefore food items that contain acid, which are excreted by the bladder, cause irritation of the bladder. The bladder by itself has a protective lining. Underneath the protective lining are bladder nerves, and underneath that are muscles. And therefore, as a result of the disease condition, once the acidic contents are consumed, it causes irritation of the bladder lining, and as a result causes nerve fibers within the bladder fire off, causing bladder pain. And as a result of spasm of the bladder muscles, it causes frequencies that is associated with the disease condition. The diagnosis of interstitial cystitis is a combination of both a history and a physical exam. History, as we alluded to, which include urgency, frequency, or bladder pain. However, typically patients do not present with those 3 symptoms altogether, but either have urgency or frequency to go along, or have bladder pain to go along with frequency or urgency. It is uncommon to find that the patients have all 3 symptoms of urgency, frequency, and bladder pain. However, that is not invariable. The American Urology Association has clearly defined this as a diagnosis of exclusion, which means that, however, when patients exhibit these urinary symptoms, a physical exam is part of examination where we also examine pelvic floor muscles, because invariably pelvic floor muscle spasm is associated with interstitial cystitis. Because it is a diagnosis of exclusion, as part of a history, I typically give patients a pelvic pain frequency urgency symptom scale, which the patients answer, and it is used to triage patients to determine the extent of disease. In addition, the probability of disease. In addition, however, because it is a diagnosis of exclusion, a cystoscopy, although not necessary all the time, is performed. Cystoscopy is performed with hydrodistension. The aim of doing a cystoscopy is to rule out any bladder tumors, bladder lesions could be contributing to a patient's symptoms. Typical bladder findings on a cystoscopy with hydrodistension include glomerulations, which are evident on a cystoscopy with hydrodistension, where once the bladder is distended with fluid, once the fluid is released, there is tearing of the bladder lining as a result of the bladder lining being leaky. However, there is what's called a Hannes ulcer, which is pathognomic of interstitial cystitis. It is not very typical to find Hannes ulcers in all patients with interstitial cystitis because its incidence is quite low. The treatment of chronic interstitial cystitis is multimodal, like every pain condition, which includes an interstitial cystitis diet, which typically means that a diet that is void of acidic product. So your sodas, your coffee, your chocolates, your alcohol will have to be eliminated. In addition, though, there is only number one approved FDA medication, which is Elmoron, Pentosan, and typically patients are started on Elmoron 100 milligrams 3 times a day, and results will be seen after the first 3 to 6 months. Pelvic floor physical therapy plays a role in helping to relax these pelvic floor muscles that seem to be going into spasm and associated with patient symptoms. Pelvic floor physical therapy will also help with blood bladder retraining so that patients will lose that urgency and frequency associated with a disease condition. There are adjunctive therapies, which means treatments that are associated, and that would include a bladder installation, which is normally performed in the office, through a catheter, fluid containing lidocaine, which is short-acting pain medication, Marcaine, and a steroid, and in addition, heparin are instilled into the bladder, and this is thought to help to calm the bladder down. Typically, when a bladder installation is performed, the fluid is left in for up to 30 minutes before the patient is asked to void. It typically helps to control bladder symptoms for up to 4 to 6 weeks. Recently, though, there's a use of regenerative medicine, which is called real allograft. These are cells that are harvested from amniotic fluid. They are no live cells, but they are growth factors, and these can be injected into the bladder lining in areas where you have glomerations of Hannes ulcers. And although this is newer treatment, patients have been noticed to have improvement in their symptoms within the first 3 weeks of therapy.